Hi guys, welcome to another episode of The Crew Table. Today is gonna be a fun one because I have ER Dr. Anna Garvey here today, and we are gonna talk about 5 things that you might not know ER doctors are doing.
The views and opinions expressed in this podcast are our own and do not necessarily reflect those of our employers, agencies, medical directors, or affiliated organizations. This podcast is intended for educational and entertainment purposes only and is not a substitute for official medical guidance, training, or clinical judgment. Any patient stories have been de-identified or modified to protect privacy. Always follow your local protocols, applicable laws, and the direction of your medical director.
Anna, can you introduce yourself?
Hi, my name is Anna Garvey. I am a second-year emergency medicine resident at a residency program in urban Minneapolis. And I'm here today to kind of talk about 5 things that you might not know ER doctors are doing.
That's perfect. So I met Anna when she came to do a ride along with me on the helicopter. Her hospital does this really cool thing where they send residents to do a ride along. Helps give them a little bit of perspective about what happens in EMS before they see the patient. And we had the best day ever, so I had to ask her to come back. And she was telling me about things that they do in the ER that I thought were really interesting. And so I would love to just dive right into it. The first one was one that you told me about in a ride along. It was giving TPA off the ultrasound.
Yes, so ultrasound is becoming, I would say, like a regular standard of care for emergency medicine doctors. My generation, certainly, of ER doctors, but definitely those that came before me are really becoming experts at ultrasound, not just cardiac ultrasounds, which I think are more common, but gallbladder, kidney, transabdominal, transvaginal ultrasounds are all things that we are proficient in by the time that we're done with training. So when a patient comes in with suspicion for PE, right, they're tachycardic, they're short of breath, and if they come in and they're hemodynamically unstable, we, and our suspicion is high enough, we'll place a probe on their chest. We look at their typically parasternal long view, so probe facing right shoulder, and we look at the size of their right ventricle. It should be about 1/3 of the size of 1/3, and then 2/3 should be the left ventricle. And if it is larger than that, that is a sign of increased, right, like pulmonary pressure. That can be from pulmonary hypertension or, in this case, pulmonary embolism. That is enough data for us. Patients hemodynamically unstable, they have a enlarged RV that we see on ultrasound, and they're tachycardic. That's enough data for us to push TPA without sending them to the scanner at all. And that's pretty regular practice with unstable patients.
That is really cool.
Yeah, and it saves so much time because going to the CT, that could be life or death for some people.
Exactly. Mm-hmm. And what would you say would be like the worst case scenario if you give the TPA and they ended up not having a PE?
Right, so worst case scenario with TPA is that it increases risk for bleeding, right? It's essentially like a thrombolytic, so it increases risk for bleeding, not just where we want it to, but also where we don't want it to. So the risk of kind of intracranial hemorrhage is the biggest, scariest complication that can happen, and I have seen it happen, but more often than not, it does help.
Would you just keep them in the hospital for observation?
Yep,
after?
you keep them. Anybody who gets TPA isn't going home. They buy themselves a stay, but if they're getting it, they're probably sick enough to stay anyway.
Right.
So yeah, we watch them in the hospital essentially until they kind of get back to baseline, and we're sure that they're stable again, and we also figure out why they had a PE in the first place, if it was provoked, unprovoked, and then what their anticoagulation looks like as they leave.
Perfect. That's super cool. That was something that I didn't realize you guys were doing, so I thought that was really neat.
I would say ultrasound guides a huge part of our practice now. We are very fortunate to have it because it's so much less radiation, it's so much faster, you can do it at bedside, and it guides a ton of our practice. Going to surgery for a gallbladder, that's all based on ultrasound. We can diagnose kidney stones without a CT scan on ultrasound, so you really get to avoid a ton of radiation for people.
That's awesome.
Yeah.
Did you know before you did your ride along that we use ultrasound in flight?
I knew that you had used ultrasound because at my training program, we had actually talked about how they were using ultrasound in flights.
I think we utilized your hospital too for some of my training.
Yes, we're a huge EMS hospital, a huge ultrasound hospital, and they had talked about that you guys are doing it on flights, and that is so cool.
Yes.
Especially because you are doing essentially the peak of emergency medicine, right? You get to them first.
I like that, the peak.
It is, though. That's exactly, like, that's why we go into emergency medicine, is to be there at the emergencies, and but the people that are actually there first are you guys, right? Especially flight, when you're going onto a scene, that is like, you are doing like raw emergency medicine at its most
with a lot less like
peak.
Diagnostic tools usually.
Way less. You have way less materials, way less resources. Like, I have heard stories of you guys have to do work in fields, you work on beaches, things like that, and all you have is what's in your helicopter. And so, like, you having the ultrasound skill opens just such a huge door for what you can diagnose and then treat out in the field before I even see them.
Yeah, I will say when ultrasound rolled out into the pre-hospital setting, there was a lot of pushback because everyone was like, what do I need that for? Do I need a fast to know if they're bleeding? And I'm like, you're looking like so small picture to what we could use. Like, and I've had ultrasound change my decision many times.
Really?
And I've been like, wow, I can't imagine if I didn't have ultrasound and I made a different decision with this patient. So I think, right now, obviously we're not giving TPA in the field, but what if in 10 years, if like we don't buy in now on the EMS side? Oh my God. Back to our regular scheduled program. My argument is, if you don't buy in now on the easy stuff, like doing just a normal EFAST, you're not going to be trusted in 10 years when we try and progress the profession to do more advanced skills if you don't buy in on the easy one. So that's always kind of been my argument.
Yeah, I think that's totally a great perspective to have, because that is the future. That's where it's going. It's already there. And it's happening in the ERs, and what happens in the ERs is going to happen in the field. Ideally. Yeah. So, I mean, think about your flight team, which is amazing. We were talking about this before the cameras came on, does ECMO in flight, pre-hospital, which is so incredible. But to be able to stick a probe on somebody's heart, see that they are hypotensive, and then see that their heart's barely squeezing, boom, they're in cardiogenic shock.
Exactly.
You know they need VA ECMO. And you just made a decision that could get the ECMO team out there X amount of minutes faster, and those minutes are, life.
We use it to guide our resuscitation. So we're using it during cardiac arrest to see what's actually going on, looking at the carotids, even looking to make sure that we have proper placement with our Lucas device, so that we're getting the most out of our compression. So just little things that sometimes people don't think of that we can utilize it for. So, awesome. Okay, number 1 was great. What do you have for number 2?
Yeah, so number 2 is that ER doctors are now being trained, and have been trained, but are definitely now being trained in doing nerve blocks at bedside, so we do not have to sedate people to, debride burns, to put arms back in place, to, fix bones, anything like that. We can do that all with nerve blocks.
That is so cool. So I haven't worked in an ER for probably 6 years, and I don't remember, maybe once or twice, them doing like a localized, like a nerve block. It was always conscious sedation for anything.
Yeah, just in my shift yesterday, I did 3 nerve blocks on patients I had to reduce a joint, I had a broken bone I needed to reduce also, and then there was a pretty gnarly wound I needed to debride, and so, fun. Or not fun, maybe. But those can all be done with nerve blocks, and again, nerve blocks are all done by ultrasound. That is all.
Full circle.
No, it's full circle, right? All of our nerve blocks are ultrasound guided, and it really helps you actually learn the nerves of the body and where they go, right? If they have a wound on X finger, what nerve do you need to block? Do you need to block multiple nerves for that? How much anesthetic can a person get before they get sick? There's something called LAST, which is, again, essentially like lidocaine-induced toxicity. That can be pretty scary. But yeah, that is a very regular thing that happens. Sedations are happening much, much, much less than they used to. If we can block it, we'll block it.
That is so cool. What's your least favorite one to do?
Let's see. I don't love the supraclavicular, which gets like the arm. It's great, but it's just like harder to get, and you have to like get around their bone, and they are more freaked out, the patient, because you are ultrasound big needle and they can see it all happening all the time, right? Like even if you have them turn their head, they're still seeing and bearing witness, and that will stress them out, where sometimes, you know, if it's a little farther down their arm, the needles are not always the smallest. So
I like how you word that.
Yeah, so you like them to turn away a bit for that. Yeah.
Okay, very interesting.
Yeah.
I love that.
Yeah.
Okay, let's move right into number 3.
I'd say the third thing that ER doctors are doing today is that we are really completely the masters of the airway. Anesthesia is amazing. They are awesome. But rarely, at least in a lot of teaching hospitals and level 1 trauma centers, do you see the anesthesiologist in the emergency department, at least in my experience. The ER doctors are really now the experts of airway. I'm very fortunate to be taught by one of the leading experts of airway management in the country, Dr. Brian Driver. And it is all about how do you manage a crash airway? How do you manage, like, from, you know, the very most pristine airway, make sure you're doing it perfectly, and then what do you do when it all goes to crap? And you have to be prepared for it to do that every single time. So anytime that a bloody airway comes in, patient vomiting, airway trauma, gunshot to the face, that's all the ER doctor is managing that. I was told about a case by an attending of mine where this patient had his entire face blown off, and it was just essentially a hole. And they had to figure out how to intubate and aerate through this random, like, essentially empty hole down into the trachea. And that is ER's bread and butter nowadays, which is kind of amazing. I think that people often think anesthesia comes down, but that is now 100% ER doctors in many, many hospital settings.
And think, like, too, say you graduate residency and you were to end up in a rural ER somewhere,
right? You
are going to be probably the only airway expert at that hospital for anything that could come in emergently too. So that sounds like really good experience.
Yeah.
All right, I have a question for you.
Sure.
What do you consider a true crash airway?
I would say a true crash airway is that they are unbaggable.
Okay.
You cannot, like, there's no way to ventilate this person. They, for whatever reason, edema, blood, vomit, whatever, you cannot bag them. Or, right, they are so full of secretions that if you are bagging them, you are pushing that vomit, that blood, that pus, whatever, down into the lungs again. So that is, they cannot breathe, and the only way that we can get in is with tubing them, and if tubing them doesn't work, we have to crate them.
Are you giving paralytic sedation on crash airways?
Yes, like as it's happening.
Got it.
Like as it's happening.
Yeah.
But yes, they are given, and they work very fast. So by the time that you get your supplies out, which should hypothetically already be out, right? But sometimes patients just show up. The worst thing is when you get a page overhead, right? That, you know, patient has arrived and you walk in, it's a nightmare. But if you have your supplies out, even before the patient arrives, you can tell your nursing staff to have pulled up those meds so patient can come, they can push the meds immediately as soon as they get access and tube them. But we do awake nasopharyngeal intubation, so patients are awake and we intubate them through their nose.
How do you feel about that?
I think it's awesome. It's totally necessary sometimes. Like, there are sometimes when it is not safe to put a patient to sleep. It is not safe to even lay a patient flat to intubate them. And if it's the only way other than criking them, it is, I think it's a great tool. They actually have, in our 3rd year of training at my institution, they have us all intubate each other.
Oh, no,
through the nose.
seriously?
Yeah. Yeah.
So that'll be next year for you?
That'll be next year for
So
me.
you have something to think about for the whole year.
I've been thinking about it. I've heard a very unpleasant experience.
Gosh.
That it hurts pretty bad for a couple days afterwards as well, because it breaks.
Oh, I'm sure.
The concha we have in our nose back there, so you can actually hear those breaking as they go in. But it's good that you know what the experience is like, because your patient's awake, they are alert,
right.
they know what's going on. So it's good that you know what they're going through.
Oh my gosh. Wow. That's so insightful.
Yeah.
I had an airway the other day that I'm like, this, like I would love to take an airway expert and then put you guys like in the field and let you like go on your playground.
Yeah.
We had an eCPR patient, so that's like ECMO CPR. So we're flying them in cardiac arrest with the hopes that they will be a candidate for ECMO, and just like extraordinarily bloody airway. And on these eCPR patients, we don't stay and play. We literally swap our Lucas for theirs, give them our backboard, and we go. So everything is done in the air. And the ground medic was like, hey, I can't even get like a good visual field. There's so much blood. So I'm like, I don't think this blood is coming from his intubation attempt. I do think he's probably having an OMI, but this blood is coming from somewhere. It was so profuse.
Yeah.
And in our airframe, the patient is next to me, and there's no way to get behind their head because there's a seat here. So when you're intubating, you're like, you're like trying to get over.
Yes.
And I have a really bad shoulder. I've had 2 shoulder surgeries, so this is totally my issue.
Yeah.
But this motion on my arm makes me want to cry. And so I'm like trying to scooch in to like the front of it. Yeah. So there's like the pilot seat and the front seat, which you've sat in.
Yes.
And I'm like getting in between. I'm almost like sitting up where the pilot is to try to get behind their head.
To get in.
And it was so bloody. It was just like taking a while like to suction, and my arm was getting so tired, and I was like, I'm about to make this a 2-person problem. And I said to my partner, I have a great view, hold the lure, just go right here. So from the other seat facing me, he's like, are you serious? I'm like, yeah, just hold it for me. So he just, from the other side, held it for me while I finished.
No, I feel like emergency medicine, which you guys are completely practicing, right, is a total team sport.
But I'm like, why not? Who says I have to be the one? Like, whatever. I can see I have a view.
The resources you have to get it done.
I'm all about being a team player.
When you're out in the community, like especially rural critical access sites, I have heard stories where they have asked like janitorial staff to hold pressure on things, or because if you need the hands and it's an emergency situation. That's what's so cool about emergency medicine is there's so much science behind it. And genuinely, I think I didn't even realize until I became a resident how much research goes into everything, every single thing that happens in the emergency department.
Let's finish, let's jump into number 4.
Okay.
Because there's some more things I want to get into.
Yes.
All right, so what's number 4?
So number 4, I just want to talk about kind of the penultimate high acuity, low occurrence procedure that ER docs do, which is the clamshell. Everybody's heard of it, right? We know kind of the concept of it, but why on earth would you ever do that? And what does that look like? So clamshell, right, it is where you do bilateral thoracotomy. So you cut open both sides of the chest, and then you actually take your raptor scissors and cut through the sternum to open up the whole chest, and then you open it up like a clamshell or a mouth. I have only ever done this on cadavers, and many ER doctors never do it in their life, thank God, because that person is very ill if needed. But one that would be indicated, right, is typically like penetrating trauma to the chest. So say, right, like stab wound on the left, stab wound on the right, they can get in on, right and left. They can get in on the left chest, do drain the pericardium if they need to, pump the heart if they need to, repair any bleeds that they see, clamp the aorta on that side. And then on the right side, if there is a stab wound to the lung that's causing bleeding into the pleural cavity, causing a hemothorax, they can, repair that, stop the bleeding, and stop the refilling of the hemothorax. So those would be the kind of indications of it. It is not done frequently because it is not a highly survivable procedure. But if it is the right patient where you know that it's not blunt injury, it's penetrating, there's a target that you can get to, and you have general surgeons behind you that are ready to take them to the OR, do definitive treatment, then you can go for it.
Is that the benefit of doing the full clamshell, is you can get to both sides?
Yes, you can get to both sides. So if you need to open both, and you, cross-clamping the aorta, say you need to do pericardial drain or pump the heart or whatever, and also that there is a penetrating injury causing bleed on that side, that would be the case that I can think of as a second-year emergency medicine resident that would cause you to go in and do something so extreme, because if you know you have a target that you're actually going to, and not just opening up to see what you can see, then it potentially would be worth it.
Yeah,
to do
that's
that.
cool.
Yeah.
Oh, that's wild.
It is crazy to
That's
see.
one of those ones where it's
Yeah.
like when it's time, you just know it's time to pull the trigger. You just got to do it.
They teach us, right, that the hardest thing for any of the quote unquote, like, I wouldn't say scary procedures, but the ones that make you like, okay, like, right, your crikes, your intubations, yes, but definitely your crikes, your thoracotomies, anything like that. The hardest decision that you have to make is to do it. Exactly. And often in those, that goes for pre-hospital as well.
Yeah,
right?
we have the same saying too.
Mm-hmm.
Yeah.
Is that right? Like, you're gonna be huge thing about emergency medicine, pre-hospital medicine is that you should be like humbly fearful of like what you're getting into, but like the bravery is just like being like, I have the skills to do this and I know how to do it, and then doing it. And sometimes you surprise yourself and actually I'm like, oh, that worked.
Yeah, exactly.
Great. Yeah.
It's like something comes over you, takes over you, and you do your training and get through it.
Yeah.
Okay, what is number 5, our last one?
So last one is kind of a little bit different than like the heavy, gory, classic ER stuff. But a huge thing that is very prevalent in ERs these days is buprenorphine induction. So we obviously know that substance use disorder is profoundly prevalent in not only our community here in Minneapolis, but also nationally and honestly internationally, but definitely nationally. And back in the day, people would get started on pretty low doses of buprenorphine for their substance use disorder, and it wouldn't really help. And it got kind of, I would say, a rap in the substance use community of not being that helpful. But, we are not using, your grandma's buprenorphine anymore. We are able to, in the ER, if people come in and they are in full-blown withdrawals, we are able to do something called macro induction, where we start them on a very high dose of buprenorphine, about 4 times as high as we were doing many years ago, and essentially give them a way to go through getting off of the substance without horrible withdrawals, right?
That's
and
amazing.
We're not giving them another drug. I think there's a thought that it's like, exchanging a drug for a drug. But the science behind it is that when substance users are using for so long, their receptors just kind of decrease in their body. And so all we're doing by giving them buprenorphine is bringing them back up to kind of the baseline that everybody else is at.
That makes sense.
Yeah.
Okay, yeah.
So because all the receptors are like, they're downregulated and things like that because they're using substance. And then so we are just bringing them back up to baseline, and it has extremely excellent data with helping people get off substances. And you can go to pretty much any ER, and that provider should be able to get you on buprenorphine, or if you are transporting a patient with that, or that they have substance use, or you give Narcan to somebody who just had an overdose. It is a lifeline to offer people in those situations that you do not have to go cold turkey. And we have new medicine, new data to show that these higher doses are safe and effective in helping. So
I love that, and I'm really glad that you brought that point out. Some of the human side too, of medicine is, we help all kinds of people with all kinds of issues, and I appreciate that you touched on that. Yeah. So that's good. Yeah. Speaking of data, now that we've covered our 5 points, I would love to bring up a topic with you that I keep seeing resurfacing in the EMS community, and it's this discussion around Reboa. And I feel like pre-hospital clinicians, they just itch to want to do this. What are your thoughts?
No. My thoughts on it, and these are not my own thoughts. These are I work with some of the best EMS physicians in the country, and they are excellent providers and teachers. And the data does not really show much, if any, no mortality benefit. New studies have come out to show that there's not any mortality benefit with it, right? And it's a pretty risky procedure to do, right? It could easily result in loss of limb, especially if not done properly. But it is not something that our hospital system, our EMS system does at all anymore. I have never learned, other than it is like a concept that used to be, I have not learned about it as a practicing ER physician, which says a lot, because I do feel like, right, if you are in ER residency right now, you are learning the forefront, and it is not taught to me at all as a tool, as something. It is more so as a relic of yesteryear, in the way that it was done like maybe 2 years ago, but it is not being done anymore. And we officially like took it off of even the list of options for pre-hospital and in-hospital, I believe end of last year.
Thank you for that insightful information. Hopefully that helps answer some questions. Maybe alternatively, obviously we're still using tourniquets, but how do you feel about junctional tourniquets? Yeah, I think junctional tourniquets are a great idea, right? That shows to have mortality benefit, right? Yes, they may lose their limb, but they may live also, which is always the thing. So yeah, tourniquets in any capacity are always preferred, and are still utilized across in-hospital and pre-hospital, but REBOA is a no. Okay, I love it. Thank you for weighing in. Perfect. Okay, one more hot topic. C-collars and backboards. So the data for C-collars is not great, right? And it's hard as like a person of science, and I'm witnessing this transition right now currently, and it is as it is a hot topic in pre-hospital, it is something we talk about in the emergency department. Does the C-collar actually work? The data doesn't show it. Hard to not follow the data, right? It is something so institutional that C-collars have been put on since the dawn of, it feels like, emergency medicine. And so it's something that we still do. Do I think that practice may change in the future? I do. Just because it is a hot topic, there is more research going into it currently. Emergency medicine is very science-based, and so if the data ultimately shows us that C-collars do not have benefit, the backboards do not have benefit, as the data has somewhat been suggesting up to this point, I do imagine they may go away. But there is also a concept, I think, that we use them to make ourselves feel better at this point. Yeah. And like I was a patient I had who had an unstable C2 fracture with a piece of his vertebrae kind of abutting his vertebral artery, and was just like tickling it. And I was like, I put him in a C-collar because I was just wanted some stability. Yeah. Even maybe a reminder, like not to move. A reminder. Even. Or no, that's a great way to think about it. A reminder not to move, because the movement is dangerous, surely, but more research is being done on the area, and I do wonder if there will be changes in practice over the next years because of that. But right now, I don't think that even as a specialty, we're ready to give it up. And it may just be person. What's interesting is, so I flew in the South for a number of years before I came here, and we had already gotten rid of backboards. Really? And then I came back up here where I feel like things are pretty advanced, and people were back on backboards. So I think sometimes too, it's a little more regional too in the country. Okay, that's interesting. Yeah. I think there is definitely a role for backboards if there's any risk of needing like CPR, obviously. Sure. For us, it helps us move the patient, honestly, and load them. So that's. But do they need to be on a backboard? Not maybe for spinal. Yeah, or for spinal stuff. Yeah. Yeah. Okay, I want to ask you a couple more questions while I have you here. One of them, obviously, I mentioned Anna came and did a ride along with us, and really we just hit it off. We talked about all kinds of fun stuff. We even talked about how our like beliefs outside of medicine like kind of intermix. I grew up very religious, but now I would say like I'm very spiritual, and we talked about like how do you like integrate things outside of medicine? Because you're obviously a woman of science. Yes. How do you integrate some of the more like spiritual stuff? Sure, yeah, that I also grew up very religious. I would also now consider myself spiritual. But I would say that being a woman of science leads me actually to be more open to the other. Because, we are so clear, and the more you learn, the more you realize that you don't know.
So there is this phrase said by someone that the more that you learn, the more you realize you don't know. And it's all based on the Dunning-Kruger effect, or the Valley of Despair, where, the more you learn, the more that you realize that there's a vastness that you can never know, that you will not know, and that you do not know. And so as a woman of science who believes science, who am I to say that that stuff is not real? And if anything, it makes me more open to it, because there are things that have, I've learned beyond my wildest imaginations. And the fact that that exists in the world makes me believe that there is possibility for other things beyond my wildest imaginations to exist in the world, such as, I know things that we had talked about, right? I don't know what is all true in the world, but, witchcraft, magic, people who read the stars, things like that, who knows? Even with paranormal things, ghosts and aliens and things like that, who am I to say?
So I just really appreciate you saying that. I know this is getting away from the evidence-based science a little bit, but I think it just shows a little bit of humility. Yeah. That the more you learn, the more you just realize how intricate and wonderful the whole universe is. And sometimes who are we to say, but I also think if you have something that you believe in that makes you feel good, makes you maybe be a better person, maybe manifest positivity, can that be all bad? But it's just the idea that you are manifesting positivity in whatever way that fits your belief system, whether you're an ER doctor or a nurse or a paramedic or somebody not even in medicine. So I appreciate.
And I think that opens you up, though, to also be more empathetic to the patient population that you see, right? We see the most vulnerable. We see everybody, right, from the absolutely most, on paper blessed people, and then the most vulnerable, underserved populations, and it makes. I think we don't understand a lot of things that we see, but it kind of opens that empathy as, that is how they live. And even there are certain decisions that people make that that maybe wouldn't be what I would make, but that makes them happy. People that, for example, for me, there are patients that I have that I can offer, that are unhoused, that I offer shelter, and they want to live on the streets. That is their home, that's their way of life. And that is something that I maybe can't personally understand, but if it makes them happy, if it brings them joy.
So you try to treat them within the context of their situation.
Yeah.
The best you can. Yeah.
And I think that's what you have to do.
Yeah.
And then just to add on that, I think life is more fun when you have a little whimsy.
Yes.
When you allow yourself to be a little playful with what you believe and what, you see to be magical and special. I'm definitely try to idealize that in my life, and I've been much happier for it.
I love that.
Yeah.
I love that. I think that's even good advice for anybody. Okay, and then just wrapping up the ride-along, do you feel like your EMS ride-alongs that you did in residency have helped you understand better what happens before the patient gets to the hospital, or changed your perspective of EMS?
Absolutely, yeah. My dad was a paramedic, firefighter, so I had a concept of it, but I'd never, obviously been on ride-alongs. But yeah, it really opens your eyes to what the challenges of being a pre-hospital provider, right? You are seeing scenes that we do not see. You are experiencing domestic situations that we do not bear witness to, and you are also you arrive at the cases that do not make it to the hospital.
True.
So you see those specific challenges that you guys have that are something that we are really shielded from inside the walls of the emergency department. And it also is just really showed the sense of community with pre-hospital providers. That is something that is so special and so sacred. And you made goulash for all of us at the house, and I had never met you, and you made me a meal, and we shared that, and we communed over a meal. And so that was seeing the community that you have, to be able to support each other through the struggles of it all.
Yeah.
When they don't, when they code in the ambulance, when they code in the helicopter, when they don't even make it on, I think was really amazing. And also to see the resources that are available certainly I think the concept of EMS back in the day used to be kind of a boys club. You know, you take it, you just have to suck it up and take the pain, and this is how it is, and quote unquote be a man or be strong or whatever. But that is like not reality, right? You are seeing horrible things, and because you are a human being, whether you are, you know, man, woman, whatever, you are going to feel and experience trauma. And maybe that shows up differently for some people, but how trauma shows up is not wrong. And so to be able to kind of be mature enough to identify that, hey, what I saw today was really hard, what I experienced today was really hard, was kind of amazing also to see that when I had been on challenging ride-alongs, and to see that there was so much, you know, critical crisis incident support staff around. Now I really had seen a shift that I was pleasantly surprised to see, right? Were there still undertones of it everywhere, kind of the like macho, I can suck it up? Yeah. But to see that people were, you know, allowing themselves the really space to say that sucked, and to talk about it and express that things were challenging, was also kind of a really beautiful human thing to see as well, and a really special kind of evolution of the specialty I'd seen. So,
I love that.
Yeah.
That's so good. I will say too, like you talking about the boys club a little bit,
Yeah.
not that this applies, but all the residents that I've had ride with me have been fantastic men and women, but especially the girl residents have been amazing. And every one of you have been like, you should go to med school. And if you do, here's advice, and you can reach out to me, and here's my number. And you guys have honestly been so wonderful, and that's been like so refreshing, because obviously as a physician, like I hold you in such high respect. So for you to come in and just be like, I'm so happy to be here, and like, what are you guys doing? You know what? You should do it too. It just was like really encouraging. So
what is really cool is that, at least I think with a lot of emergency medicine residents, is like you have a bunch of people who are genuinely passionate and nerdy about medicine, and the people that they see, right? Pre-hospital providers, ER providers, they have to be a certain person that can be open to every experience, every person, because they're going to see that. And so I'm really happy you had that experience, because that's been my experience.
Good.
And also in my class, there is 16 people, and 13 of them are women.
Ooh,
So,
what a ratio.
Women in STEM.
Tables have turned.
Yeah, tables have turned. Yeah.
Okay, so speaking of residency, have you heard this adage of like, oh, don't get hurt on July 1st because that's the day residents start. You don't want to be in the ER. How do you feel about people saying that?
I mean, it is a truth that you will very likely be seen by an intern. If you were hurt on July 4th of last year and you came to our hospital, there's a chance that you saw me. And I had been a doctor practicing for about 18 days at that point. And I was seeing, I mean, I put central lines in people, I was doing, but it's all, everything that an intern does, it's not like they're cowboying alone out in space, right? They have gone to 4 years of college, often a master's degree. Some of them have a PhD, and then also 4 years of medical school with clinical rotations, right? They're not coming onto the scene with nothing, but to learn practical medicine is something you have to learn.
And you still have oversight, right?
You have oversight. So it's me, right? I say I'm an intern, I'm doing work on a patient. My third year pit boss is what they call them, is overseeing me. And also I have an attending overseeing me.
Right.
And never once have I ever felt that I was in a situation where I was dangerously alone. And if I ever saw it moving to a place, right, you have enough wherewithal to be like, this patient is sick, and we are encouraged and, you know, rewarded for going and saying, this person is sick, I need another set of eyes on them, to get somebody who is more experienced in there. So yes, you may see an intern, but you're not just seeing an intern. You're seeing their senior, you're seeing the attending. There is safety, and I think there also has to be some grace, is that people have to learn. And yes, you sometimes make mistakes on your way there, but everybody, EMS providers, nurses, techs, you know, everyone has had to be there on their day one. And so giving a little grace to those individuals, knowing how scared they are, knowing they've worked for 10 to 12 years to be there on that day, and yet feel so fearful and know there is also, we know that people are afraid that we are going to make mistakes too. So just giving everyone a little grace and kind of going forth with like a learning attitude and a teaching attitude even is the way to do it.
Thank you for clarifying that for us. I think that's important. I hear it a lot, and I think if somebody said that about the nurses, they would be like outraged.
Yeah.
You know what I mean? So let's not. I just really appreciate you clarifying that. Because there's so much oversight.
Yeah.
I'm sure, and everybody has to learn.
Yeah.
So.
Again, medicine is like with nursing, right? It's not. It's all about safety. It's all about data. It's all about metrics. We're not just gonna let somebody who's never seen a patient before go in and open somebody's chest. Right. Like that's not happening in the world. May they sew up your laceration? Yes, but they've been doing that for 2 years in med school. Like, they are going to be doing what is appropriate for their level and not beyond it.
Exactly.
So.
Yeah, perfect. Yeah. Okay, so summer has kicked up. People are outside. They're doing things. They're getting busy. What's interesting, so you are at a level 1 teaching hospital. You see children and adults.
Yes.
Yeah. So what would you say is the most common pediatric injury that comes to the ER?
Injury.
Specifically the kiddos.
Yeah, I would say that for them, it would be like bone fractures, and then sometimes associated with head injuries. So I would see. So people are out doing stuff. They are not necessarily observing their kids as much, or kids get up and they're on playgrounds and they're on things like this. So a lot of, I would say, fractures that we see. I said that I had done some nerve blocks recently. One of those was on a child who broke their arm, right? So that's kind of the most common thing we see. But we do also see an uptick in like drownings and things like that also. But kids are so resilient. It is so amazing. What adults could only dream of coming back from, kids can. So kids will code, or we will work on a lot longer, maybe because there's the emotional aspect of there's a kid, but typically it's because kids are so surprising on what they can survive. It is outstanding, and cannot be understated that like if you come across a child, it is worth working them because they could come back.
I'm glad you said that.
Yeah.
That's interesting. So in regards to drowning, and I speak about this because it is public and it has been shared like publicly online, this kiddo's recovery. LifeLink did what we know as the longest case of CPR in a pediatric patient in the world. Recently. It was, I don't want to misquote it. I think it was like somewhere between 6 to 8 hours.
Wow.
So this kiddo had drowned.
Yeah.
It was a cold water drowning.
Cold water.
And the hospital recognized that as an ECMO patient that would benefit from ECMO but didn't have the ability. And so through coordination of multiple aircrafts, we sent fixed wing to go get him, and he's not big enough for the Lucas. So our crews took extra crew members and did manual CPR for hours. Ambulance, hospital, back to the airplane, in the airplane to a helicopter, that the helicopter then flew him here to Minneapolis where he could get put on ECMO, and he made a neurological recovery. And the crew got to meet him the other day.
Is outstanding.
Isn't that insane? So just think, when you talk about resiliency, can you imagine doing CPR for 6 to 8 hours and having somebody neurologically intact?
That is unbelievable.
It gives me like a little bit of chills.
No, that's literally
it's so
chills.
Amazing.
Like, and this is kind of, even though, yes, I know that it's like, that's like the magic of it, right? That's where like the magic is in medicine, because like that child should not be alive, right? Like that does not, like it, but child's bodies are so resilient. He was in cold water, which, helps. And then to have so many, and it cannot be understated, the importance of having all of your crew members are excellent at doing high quality CPR.
Even we have to credit his parents for starting.
Wow.
Right?
That's
resuscitation
absolutely.
And ground, like every single chain of survival had to give high quality.
That cannot be understated. That, everybody did that. So, your CPR was so good that he was getting enough blood to his brain that he didn't, the evidence is right there that he has full neurologic recovery.
Yeah.
And that is
so crazy. I always think it's interesting how it's like you could watch somebody drop, do CPR, work them, and never get them back. Or you could have somebody that you work on them for hours and they're fully intact. And yes, obviously there's so much science that goes behind perfusion and all the other things that go into resuscitation. But I always wonder, what is the point of, how do I word this? The soul is out of the body and it's I'm out, bye.
Yeah.
Where is that line of like, did you stay in there the whole time and then we got you back and you had never left? Or like, are some people just like gone and like, that's why they're not, it's
that
like
is,
a little,
that's so
I just always
interesting because I know
wondered
that you've seen this, right? Like
Yeah.
you see when we witness death very regularly in our jobs. And it is very notable when they die that is now a dead body.
Right.
It is very noticeable and like visually very noticeable. And so you wonder, right? Yes, maybe they just look like that, right? They're not having blood perfused anymore, so they're pale, blah, 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 blah. But is it also because like the concept of a soul like is gone?
Yes, the concept that's worded
and it's like I can't say, and I don't know, and I know, right? You hear all these people have these experiences
where
they're
they're like,
where they're hovering over their body,
Yeah.
and I can rationalize that and say, their brain isn't haywire, and they're having like some waking sleep paralysis, but when the stories where they are seeing things that they shouldn't have seen, where they are knowing things that happened in their case, that because they say that they're looking over, like that is unexplained. And I don't have a good reason for that, but that is notably unexplained by like what we currently know scientifically.
So interesting.
So
yeah, well, we just give everyone our best effort,
Yeah.
right? And
who says that stuff is not, that there isn't a like connection with science there that we just
maybe
don't
we
know
just
yet.
haven't researched it yet.
Yeah, like we
I just
don't
always
know.
say like we're trying to keep people on their current timeline. Sometimes we do, and sometimes we don't.
we do, and
Sometimes they
sometimes
go
we
to the
don't.
next.
Yeah.
And they become part of our timeline. So
Yeah.
it's kind of all right. Last question before we wrap it up: if you had to give one piece of off the wall advice to somebody that wants to get into like EM residency, that type of medicine,
Yeah.
what would you give?
So I would say if I could give any advice to somebody that wants to get into EM, is that any like life experience that you have will make you a better doctor. So do not feel committed to the regular, I go to college, I go to med school, I go to EM, I'm a doctor. Like it is like okay to take time. It is okay to live life. Be a flight nurse. Live like a beautiful, wonderful life where you have many diverse experiences, you meet diverse people, you interact with people of different cultures and backgrounds and identities, because those are going to be your people. So it has been such a gift to me that I was able to live a life where I interacted with so many people from so many walks of life before I became an ER doctor, because these are now my people. These are the people I see, and I can now create some sort of connection, some sort of community with them, and my life is so much better for it. And I'm allowed to give myself the permission to be empathetic to these people, because I have seen, I have known, And so emergency medicine is a very open and very community-based field, and so allow yourself to create that community. You don't have to go straight through. You can live a diverse and full life and also be an emergency medicine doctor when it's time, because everything that you are doing up to this point is helping you be a better doctor for your patients. There is no timeline, so don't worry if I took 5 years off, and I traveled, and I led support groups for mental health services, and everything that I did, even though I was so worried that I was getting left behind, made me a better doctor today. And I think that is the best advice I can give. There is no right timeline. If anything, the life that you are living now is going to serve you in the future. So when you feel ready, then that's the time to go.
I love that.
Yeah.
I want to end on that, but I want to ask you. You. Tell us a little bit about what you did before you went into EM.
Yeah. So my first job out of college, in college, I majored in biochemistry, and my whole special interest actually was genetic engineering. So my friends and I essentially we worked with a genetic engineering team essentially, and we got to lead the team, and we had kind of a substantial amount of money for a student-led group, and we got to create what we called biomachines, right? And it was essentially just a group of friends who worked really hard to make these, and we were working to make a probiotic that digested cellulose into calories that we can metabolize, right? If we eat grass now, we do not get calories from that. We eat grass and we poop grass, and that's what fiber is, by the way. But in more, lower resourced countries, livestock do not have, it's expensive to buy food for animals and livestock and things to feed the people, the families, the community. And so the goal of this was to create a probiotic that could be given to actually these animals to break down the grass that they were just grazing on throughout the day as to be used as calories. And so when I left the area, we closed kind of our touch on that chapter. But I know there was potentially some talk about trying to make it into an actual capsule, but we had made the bacteria and we had the data that it did break down like cellulose into calories. So it was a really cool, fun thing. I mean, genuinely, it was me and my best friends. And they really became my best friends because of this. Some of us would sleep on cots outside the labs because we were just so passionate about it. And so that was kind of what I did in college. And then afterwards, I worked as a barista for a little bit because I had always wanted to do that. And then I ended up working a contract job where I would in the medical field. And when I would complete my contracts, I would just go and travel the world until my money ran out. And then I would pick up another contract and then travel again.
That's really cool.
I also led support groups for people struggling with mental health and also their families. So I tried to keep a really diverse life, always knowing that I was going to go to med school, but I wanted to experience, some different variations of my happy life before I kind of got on the path of medicine, right? We all have very many happy lives that we get to live, but certainly I've been very fortunate to, make mine very full as we go on.
I love that.
Yeah.
Thank you so much for sharing some of your life with us today and your knowledge. This has been so fun.
Yeah, I've had so much fun. This has been great. Yeah.
Oh, Anna, it has been, I should say Dr. Garvey.
Right.
It has been an honor to have you speak with us today. You've given us so much insight into some really cool medical advances that the community has made. And I've really just enjoyed getting to chat with you too. You saw some of the EMS debates that we've been having lately too, which is awesome. So thank you guys for watching another episode of The Crew Table. This is the time when I tell you to like and subscribe and support us. And if you are interested in coming onto our channel and speaking or have a hot topic that you want to discuss, you can inquire with our Linktree form. We'll catch you guys next time.
Bye.